All right, we'll get started. Thank you for this wonderful meeting. It's just been marvelously coordinated, and I appreciate that. So the title of my slide really is MR-guided transrectal HIFU, a bespoke approach to prostate cancer focal therapy. And really, that's what I show you here in this image is really what the focus of my talk will be, is being able to understand what you're treating, how much you're treating, and getting appropriate margins, which may have application to many treatments in focal therapy. I have no disclosures relevant to my talk. And these are some funding. Okay, really my objective today is to demystify MR-guided HIFU, specifically the exablated device, which is a transrectal device. You'll hear about the transurethral device in the next talk. I'll talk about the oncologic and functional outcomes from a phase 2 study, and really my thoughts on some benefits and pitfalls with inboard treatment. Reason we all are here is because we thought that we had our three main treatments for prostate cancer. Either you're a candidate for surgery or radiation or definitive treatment, or you get placed on active surveillance. And I would largely agree with that, and the father of this trial is sitting in our audience, and I would argue that what we've learned is, despite our support of active surveillance, we have to acknowledge that over 40% of our patients who start with low or intermediate risk prostate cancer will go on to treatment for mostly pathologic upgrade these days. And that's an important group. And I would say if we can expand this out to 10, 15 years, we will now have a group of patients that we effectively have avoided radical treatment. And I think that is an important outcome for our patients. Why haven't we done focal for over 2 decades? The technology has been there. It's really from slides like this one. This was a study from Memorial Sloan Kettering looking at whole mount specimen. This was over almost 315 patients, and we can see very clearly that prostate cancer is multifocal. I would argue it wasn't until we really believed and made standard active surveillance for low-grade prostate cancer that we became interested as a community to treat the index tumor, which we spoke about yesterday, or the highest grade area of treatment. I'll spend the next 2 slides really describing the treatment before I get into our outcomes. This is the exablate system. It's a transrectal device compatible with all MRI systems. The table gets connected to the MRI machine, and this is an inboard treatment. The key is real-time imaging during treatment. As you can see, we see the balloon within the rectum here with the probe pointed. We annotate the prostate like we do on many systems. We create margins. I do believe in large margins up to 1 centimeter feasibility. And clearly, we can acknowledge that we can automatically start seeing the treatment as it's occurring. So temperatures, which is the key here, is reaching above 60 and 70 degrees. I would say if your system is not reaching 70 degrees Celsius, there's an opportunity for improvement. This is what we try to achieve with real-time thermometry during treatment. And I can say it was my experience for 5 years working with this system that has now translated to subsequent ultrasound-guided systems that I can say, you know, every prostate gets treated differently, heats up differently, has different acoustics, and more energy is better. Another advantage of an MR system is you get an immediate MR post-treatment study with contrast, which will allow you to then go back and do further treatment at the same time to be able to get a very uniform treatment. So I'll go into some of the details of this study that I was fortunate enough to lead. We started this study in 2014. We finally presented the results in the end of 2022. And I think a lot of what was discussed with this study has either been misinterpreted or there's need for expansion of some of these ideas. This was one of the first focal therapy studies where we included men with grade group 2 or grade group 3 disease. We have talked about in this session why I think an MR-targeted core of grade group 3 in the setting of systematic grade group 2 is different, and we believed that when we made this our entry criteria. We allowed concurrent grade group 1 at any volume anywhere in the prostate gland. This was an MR-targeted selection of patients with systematic biopsies. Every patient got a biopsy, an MRI and biopsy at 6 months. Every patient got an MRI and biopsy at 24 months. The primary endpoint was grade group 2 or higher cancer anywhere in the prostate at 6 and 24-month biopsies. We also collected majority of our baseline and subsequent follow-up quality of life assessments that I will discuss. We were fortunate to enroll all 101 patients, which was our pre-mandated entry criteria. You can see this is your typical localized prostate cancer patient with our PSA. Our grade group of note, we had almost a quarter of our patients with grade group 3 disease. Majority of patients had good urinary and sexual function, baseline function. And we look at treatment parameters. I think it's an important time point here. The average treatment duration from the patient being placed in the MR and then being removed from the MR was a little bit less than 2 hours. In regards to did we hit and treat what we were actually aiming at, you see 6-month and 24-month outcomes. This was biopsy, MR target, and systematic biopsy for every patient. Importantly, you see that the initial biopsy, the data looks excellent. It really was a second biopsy, which I would consider an intermediate time point, that really showed us even more clarity about our treatment. Despite that, we were successful in over 88% of our patients, not detecting any grade group 2 or higher disease in the treatment area. But this is where a lot of the noise of our study became apparent. When we did systematic biopsies at 6 and 24 months, we found almost an additional 25 to 26% of patients had cancer grade group 2 or higher outside of the area of treatment. I really did some thinking about this data after we had seen it and published the data. When it goes to whole mount, that will be a grade group 1. But that wasn't how we assess patients after focal therapy. We don't have the luxury of looking at the entire prostate or do a whole gland assessment, which we know pathologists look at differently than a biopsy core as far as thresholds of calling pattern 4. So the question was, what does this data represent? Does this really represent a biopsy diagnosis on follow-up? So I went into that, and this is the type of data we saw. This is across our 8 centers, all academic centers with significant experience with MRI and targeted biopsy. But amongst patients who were enrolled, we see that there's 0% up to 50% detection of grade group 2 disease outside of the treatment area. So that, to me, suggests that although we believe that MR-targeted biopsies and systematic biopsies are accurate, and I actually do believe they're very accurate in comparison to whole mount specimen, what we're getting as input from our biopsies may not represent the entire picture, but it does guide our treatments. Of note, majority of patients in this study who had grade group 2 or higher cancer remained on active surveillance, suggesting that the volume of cancer detected was very small or within acceptable guidelines of favorable disease to remain on active surveillance. When we speak about functional outcomes, I would say this represents very well what we should expect for focal therapy. Many of the studies that we see in focal therapy use a single endpoint. They'll say at 24 months, a simple arithmetic of what percentage of patients have a specific IEF score and what percent don't. Although that's very simple to do, in my opinion, we have to do more sophisticated analysis because the question isn't what is it in this study, it is what's the probability of a treatment causing erectile dysfunction or a certain decrease in IEF score. And that's how we modeled these. These are modeled results of our outcomes. And so I can tell a patient that your possibility or probability of having an IAF 24 or higher, which is a very high standard for erectile function, post-focal therapy with HIFU exceeds 70% with or without medication use or without medication use, and 90% if we allow the use of PD-5 inhibitors. Similarly, we did not see any patients with any incontinence or pad use post-treatment. We modeled that based on the ICIQ, which our colleagues in voiding dysfunction use to assess urinary function and leak. So how do these results compare to other treatments? I'll use this one slide. You'll hear more from subsequent speakers. But ultimately, what we consider the target should be the assessment of our technology. In our study, the target was a focal target. We know in other systems, the whole prostate is considered the target. So high-grade cancer or any cancer detected within that target should be considered the efficacy of that treatment. We see from this study that patients treated with the MR system, and we are waiting better data from prospective studies in ultrasound-guided HIFU. However, we see that there are differences at 12-month outcomes compared to the transrectal device, whether this is patient selection or the energy deposition, allowing us a bespoke treatment using the transrectal system, which is key. I cannot tell you how many times, I would say in over 90% of our cases, we actually changed the frequency or duration of the energy we were depositing into the prostate based on our assessment of how the prostate was moving. So the ability to modify your treatment, increase energy, is critical, in my opinion, as we think about our opportunities to improve focal therapy. This is unpublished data from our trial. We asked the question, well, why did certain patients fail in the targeted region? And so because we had MRI data, we could look at non-perfused tissue, and we see that as we increase the non-perfused tissue, which is a direct connection with our margin status at the time of treatment, we see a decreased risk of recurrence at 24 months biopsy. To describe this figure here, the gray represents different frequency and percentage of patients with different non-perfused volumes. You can see in some cases the non-perfused volume almost exceeded 80%, which was almost a hemiablation that crossed over. But we see the probability of grade group 2 cancer at 24 months biopsy decrease with non-perfused volume. This seems obvious, but this is now an estimate of what we would expect. The real question is, does it impact sexual and urinary function? Again, we see that when it comes to the probability of erectile dysfunction, this figure does not change significantly. This is the confidence intervals represented by the dashed lines with this increasing perfusion of tissue. Similarly, the risk of having any bothersome urinary symptoms because we didn't have anyone with incontinence also does not change with increased perfused volume. I think the takeaway from that is more is better. Even though we call it focal therapy, don't let that impact your margins. Here are my feelings of the pitfalls of inboard treatment. I think we've talked about this before, but access to treatment, there is access issues with MRI, and this is a major limitation of any inboard treatment. There is an increase in treatment time. You know, an IR suite or an MR suite works very differently than an operating room, so getting patients positioned under anesthesia, in my opinion, is less efficient than an operating room setting. You need a partnership. I recognize I'm in a unique situation at my institution working with IR as a partnership, but this is not feasible outside of academic institutions in most cases. There's restrictions, patient-centered restrictions, specifically with hip implants or metal within the prostate, allowing, or outside and within the body, that would limit MRI. And there's a cost to holding up an MR suite. I think the benefits are clear. Imaging quality can't be beat, real-time tissue assessment, but we can't just have real-time tissue assessment if you can't change your treatment. So the ability to really ramp up the energy to levels, you know, that we were approaching. I always joke that I had my hand on the emergency stop on every single case and use it in half of cases. I saw the energy source and increase coming towards the rectum. But being able to get that real-time assessment was key. And at the end of treatment, getting that post-treatment assessment with gadolinium to allow us to then restart treatment right away while the patient was still in bore and under anesthesia. So in conclusion, I think the landscape of technology continues to expand. I mean, just the last session with BPH, there was some discussion of prostate cancer treatments. I think we can clearly say now that our functional outcomes are superior to radical treatment. I've postulated based on this data that MR-guided focal therapy with real-time thermometry does produce excellent functional outcomes. And I think it's no surprise to this group that we are at the point where we can now take clinical trials and translate them to clinical practice and implement focal therapy safely in our practices. Thank you very much.